Order, order. Welcome to the Public Accounts Committee on Thursday the 13th of March 2025. In May of last year, our predecessor committee found that the Department of Health and Social Care and the UK Health Security Agency had been failing in their financial management and accountability for taxpayers' money for 2 years running. DHSC is one of the most complex tasks in government, with an annual budget of approximately 191 billion and an average of 1.7 million patient interactions a day, ranging from GPs, community interactions, hospitals, NH 111 and ambulance services. Whilst progress has been made, the CNAG has qualified its opinion on the DHSC accounts for 23-4 and highlighted issues within financial management and oversight of the departmental group, as well as financial and compliance issues in some of the bodies across the group. So, at today's hearing, we will constructively examine through the department's annual report and accounts what went right and what went wrong last year, as well as other key issues relating to the department's accountability to Parliament. Can I extend a special welcome today to Layla Moran, who of course is not only chairman of the Health and Social Care Committee, she's also a former member of this committee, so she knows how it works probably better than most of us. So today, to help us with all those momentous problems, we have warm welcome Professor Sir Chris Whitty, Acting Permanent Secretary and Chief Medical Officer. Sir Chris is the current Interim Permanent Secretary at DHSC and pending the appointment of a new Permanent Secretary. We have also with him on my right the Andy Brittain, the DHSC Director General Finance, and Andy has been at the department since 2020. On Sir Chris's my left, Professor Dame Jenny Harries, Chief Executive. Professor Dame Jenny has been Chief Executive of UKHSA since 2021, and I understand that she will be stepping down in this role in early summer. So I'd like to thank you, Dame Jenny, very much for your excellent work you've done in this position. It's not been easy. It was set up in a hurry. There were a lot of problems right from the start, and you've taken a lot of brickbats. So thank you for all that you've done. From NHS England, Julian Kelly, Chief Financial Officer and Deputy Chief Executive. Julian joined NHS England as Chief Financial Officer in April 2019, and this week it was also announced that you too would be stepping down. Julian, thank you very much for your 6 years of dedicated service with NHS England, particularly helping navigate health and social service through the pandemic and out the other side, and I wish you very best of luck in the future. You've always been very helpful to this committee and answered our questions with patience and candour. So thank you very much for what you've done for this committee. At this point, I'd also like to pay tribute to Amanda Pritchard, who's also been recently announced that she will be stepping down as Chief Executive of NHS England this spring. In fact, I think she's already stepped down, hasn't she? Not yet.
It's announced, yeah.
Okay. She oversaw the NHS at a time when it was under so much pressure following the pandemic, and I wish her all the best for her future endeavours. Julian, would you like to say a few words?
Only to say, firstly, thank you for your kind words. Actually, I'd say on both my behalf and Amanda's behalf. When I took this job, I don't think I really knew what I was getting myself into. It's been... Our medical director said at the time of the pandemic, this would be a 5-year journey of recovery. And I think, we are beginning to see, I honestly believe, the kind of green shoots of recovery, both in terms of we will see an improved financial performance this year with a significant reduction in the deficits in providers and systems compared to last. We will see a falling waiting list, improving elective waiting times. Our monthly polling is showing, admittedly from a low base, but improving patient access to GP services. We are seeing recovering productivity. There is a lot that remains to be done, huge challenges still to be addressed. And, I know Amanda and I will wish the new team the best of luck.
Right. Well, I think before we get into the main session, we want to, if we can, find out from any of the witnesses here exactly what is happening to NHS England, because the healthcare leaders have told us that NHSE and DHSC are to be cut by 50%. And I think what we want to try and get into is what that really means in terms of headcounts and functions and everything else. So is that Julian or Professor Chris Whitty, are you able to help us with that, please?
Shall I have a first go, but Julian may well want to add to that. So I think this needs to be situated in a sense in two areas: what the government wishes to do about the centre of government, civil service as a whole, and the Prime Minister is making a major speech this morning, which I think is going to lay out more details on that. And within that, they've made it clear they want two things. They want the centre to overall become smaller. Their view is that there were increases that occurred at various points along the lead up to preparations for Brexit and then during COVID, and they feel that there should be a clear reduction in that. They've been very clear about that. And secondly, a shift in the way that government does its business as a result of both the changes in society, which mean that you do need changes for those reasons, and also opportunities that come from things like artificial intelligence and other roles. So those are general things which have been flagged for the government as a whole. And then for health specifically, the Secretary of State for Health and Social Care has specifically said he feels that the centre should be smaller, leaner, and whatever resources can be freed up, moved to the front line. That's the first area. And additionally, he also wants to make sure that there is closer working between NHS England and the department, which was set up in a way to be very independent, and he's laid that out, that direction of travel. He's giving a statement to Parliament later on, which I think will give further details on this. So I think that's the overall background. As a result of that, what's been announced is a headcount reduction with a percentage target, which has been announced within NHS England by the incoming Chief Executive NHS England and Amanda Pratchard, the current Chief Executive, within DHSC, which does some functions that overlap with NHS England, but to be clear, does many things that are unrelated: public health, for example, science, for example, work across government in other areas. But there will be definitely a reduction there. That's been announced to staff. And I announced earlier on this week there'll be a voluntary exit scheme in the department on top of some recruitment controls already in place, with the aim of essentially achieving these two broad goals.
Professor Chris, are you able to put any numbers on both NHSC and your own department?
Well, the NHSE have chosen to put some numbers, but the view of our Secretary of State, and this very much follows what the Chancellor Duchy of Lancaster said about the civil service as a whole, is what they want to do is really review, and in my view it should be reviewed with the incoming Permanent Secretary, but either way, review which bits of the service need to change, either as an overall result of the changes I've talked about the civil service, or the specific ones that fall out of the changes with NHSE and the way that interaction between the department and NHSE occur.
So, I mean, others may want to come in a minute, but you and I understand maybe the sensitivity there. You don't want to put numbers on it at the moment. Is that correct? I mean, there's no point me keep asking you questions you don't want to answer. Well,
it's not a question I don't want to answer. If the Secretary of State was here, he would say, and you said to him, what is the number? He would say, that we haven't yet got an exact number, but the direction of travel is clear. And I'm being entirely open with you. This is what I've said to my colleagues, and that's what we're saying privately. That is the situation at the moment.
So in which case, the really important question, I mean, I think, to be fairness to the staff in your department and NHSC, when will the detail of this become clear?
Well, I think that having had the experience of going through several, both contractions and expansions within the civil service and in other organisations, my experience has been that setting headcount targets before you've even worked out what exactly the shape is you're going for is a recipe for disaster, if I'm honest. So I'm really clear that within this particular context, given that there are a variety of things we need to change, now there's a very different context to NHSE, and I think the logic of what the incoming Chief Executive has said makes a lot of sense. In terms of that organisation, the way he wants to go forward with it in consultation with the current Chief Executive and the Secretary of State. But I think in terms of what we're trying to do at the moment, given that we've got these two moving parts, what the Prime Minister and the government want to do for the civil service as a whole, which affects all of DHSC, and then the bit that faces NHSE directly, which has to interact with NHSE, that's the reason that I think our view is we do not want to do a number until we're clear what we're trying to build in from the base.
Thank you for that. That's very clear. But uncertainty in any organisation is not good for patients in this case, and it's not good for the poor staff that have to cope with these changes. So how long is this all going to take before it's clear what the strategy is, what the functions are for each of the two organisations, and then what is the consequences for staff?
So I fully agree with the premise of what you're saying. The aim at the moment is, well, obviously to, in a sense, do two things simultaneously. To make sure we are able to provide the service to the public and to the parts of the NHS and local government and social care which we serve, so that that can continue all the way through any changes. That's really critical. That, in a sense, has to be the first priority, because if we see a significant diminution of that service, that is not in the public interest at all. But of course we want to finish this as soon as we can within those constraints. So that's really those are the two things we're trying to achieve. I agree with you that certainty is ideal. False certainty is worse than no certainty. So putting a number that isn't a number we've really worked through actually does not, in my view, seem to me, at this point, given these moving parts, an appropriate thing to do.
I agree with your thought process entirely, but I'm still going to press you slightly on the sort of timetable. Are we looking at weeks, months? I think that those in the organisation, huge numbers in the organisation, and the patients themselves need some form of guidance as to what the answer to that question is.
Well, firstly, to just make the point that the civil service, like every organisation, is continually in change. So the idea that there's a point of absolute stasis, I've never seen one, nor have I seen it in any organisation I've ever worked in. So there isn't a point where you come to a complete end. But there are two bits of the component to do with DHSC, which is the one that I am involved in, for which there is a relatively clear timeline. And then there will be bits further to that, which are the consequences of the interactions with us bringing together our work with NHSE.
Would you like to just set out what your department is?
Yeah, no, what I'm trying to do. So I'm trying to give you a proper answer rather than a kind of...
No, we appreciate what you're saying.
So the two components that we've announced so far, one of them is immediate and will continue for probably some time, which is a cap on new appointments, particularly new external appointments, which leads that, because there's a turnover of staff, which on average tends to run at between 5 and 10%, but let's say 7% for the sake of argument a year, means that you can manage down without actually anyone having to leave and have a package or anything like that. Just by the natural turnover, you can manage staff down. That I'd already put that in place a while ago. We've slightly tightened the rules around that. That is from now. That is happening at this point in time. What I've then announced in terms of the next stage is that there will be a voluntary exit scheme. Now, this is in with Cabinet Office and Treasury, but I don't anticipate them saying this is inappropriate. I would anticipate that opening, and I've said this to staff, so it is very important I don't say anything to you that I've not said to staff. That would be very, very wrong. Yes. But I've said this to staff, that I anticipate that opening hopefully before Easter. And if we do it before Easter, that will, at least in an initial phase, run through till probably about November of this year. Now, what that doesn't do is take into account the consequences that need to be thought through carefully of the changes that are happening in our relationship with NHSE, and I think we need to do that properly from the base up and actually ask the question, and then the Secretary of State needs to make the final decision, what is the shape and size of the organisation we want as a result of the changes. Now, I think the first two things I've announced already are irrespective. They're really there to deal with the overall view that the overall system should be smaller, and that's a view, as I said, which is across government, as has been trailed heavily by the Chancellor Duchy of Lancaster in editorials today by the Prime Minister, and he's giving a speech later on today which will flesh that out. But I do think, I'm not saying that this is, everything will be over by November, because the process which the Secretary of State has set in train in terms of closer working together of DHSC and NHSE has a lot of consequences that need to be thought through, and Julian may well want to add to this. He may not, but it is important that we understand that those two have to interact, and this, therefore, in my view, is not a point where I can say to you, this is the exact point where this is going to end. I think there will be a further stage beyond that, and I've been clear with my colleagues who are outstanding. I've been clear with them. That is where I think we are.
Well, we'll come to Julian in a minute, but there's another important component to all of this. HSJ also say that ICBs are ordered to cut costs by 50%. Now that's getting much closer to the patient, and that seems to me quite an ambitious sort of thing to achieve. I don't know whether you or Julian want to say something about that.
I have a first go, but this is very much more in Julian's area than my go. I mean, the overall aim, which was announced by the incoming and outgoing chief executives of NHSE, is to make sure that resources and decisions are, where appropriate, taken as far close to the patient as is possible. That doesn't mean all of them can be or should be in terms of the most efficient delivery of services. There are some services which are more efficiently delivered at a national or regional or more local stage, but not absolutely at the far end. For example, science is usually best done at a national level. Some areas of data aggregation are best done at a national level, or in some cases a regional level. And there's no, it's not more efficient to push them further out. It actually is less efficient. Mm-hmm. But there are other areas where the reverse is true. So, I mean, that's kind of philosophically what the aim of it is. There is also very important budgetary reasons for this, and that drives a lot of the thinking which NHSE, I know, have gone through in these very difficult decisions. I don't know whether Julian wants to add to that.
Julian, do you want to comment on all of that?
So only to say Sir James Mackey, in coming in as the incoming chief executive, has set the target to reduce both the size of NHS England by 50% and has asked ICBs to look at how they can reduce their size by 50%, as you have just said. It will require a redundancy scheme to achieve that scale of change. I think that will be part of the conversations that Sir Chris has just referred to with the Cabinet Office and HM Treasury. Some of this is certainly looking at where there is duplication of functions, as Sir Chris has said, both between the department, NHS England, and indeed we'll have to look at ICBs. I would expect the detail to really come through as the 10-year plan is finalised, because that really will set the sort of structures that are envisaged to see through the delivery of the 10-year plan. It clearly, though, won't just be about duplication when you're talking about that scale. It will have to be a hard look at what specifically functions are being done where. And indeed, as Sir Chris has said, how more of those functions and indeed greater freedom is given to, it'll have to be providers to get on and do the job of delivering for patients.
Ollie, the scale of change in NHSE is, of course, far bigger than the department. So there will be far more uncertainty in staff. They will know the outline of this by now. When are they going to get... I mean, Chris has been very candid with us about the voluntary redundancy scheme and the freeze in recruitment. When are we going to get the similar sort of announcements for NHSE?
So we have already, or Sir James has already told staff, well, obviously, about the size of cuts coming. We have already said as a result that we are implementing a vacancy freeze with some, it'll have to be some limited exceptions. He will announce, I would suspect in the coming days, his transition team, i.e. the team that he is going to put in place. I mean, for example, whoever is going to replace me, again, I'd expect that to be in the coming days. And he has not yet set out the detail of what he thinks will be the kind of change in functions. I think that will be some work over the coming weeks with a view to, because it will also involve what is the interaction between NHS England and, as I just said earlier, integrated care boards, and then indeed how does the oversight regime work with providers.
No, I can see colleagues are anxious to come in, but I just sort of want to get the bones on this and then let my colleagues sort of pick at that. Bearing in mind our previous conversation in this committee about ICB's budgets and the lateness of being given those budgets, when are they likely to see those budgets and guidelines? So
ICBs already have the totality of the budgets for next year, so they already have those. This is clearly, I'm going to say a detail, it's clearly a significant detail, i.e. in £180 billion worth of spend. I'm saying it is a material impact, but they have the totality of the spend. This will shape effectively not the quantum we have shown them, but sort of how it is deployed, and the aim really is how do we make sure as much money is going to the frontline services this year, i.e. hospitals, GPs, dentists and so on.
So I'm still keeping lots of clouds still in my horizon here. So I'm Gloucestershire ICB. I've been given the budget, which thank you for that, because that's a lot earlier than it has been. But I've been told that I've got to halve my administration costs. But I've got a budget. Does that mean that budget stays the same, but you're expecting more to the front line?
That's exactly it, yes.
That's really helpful.
Yeah.
Anna Dixon.
Yeah, thank you, and thank you, Sir Chris and Julian, for your honest responses to the Chair's questions. I suppose, given this is a hearing about the accounts, I just want to try and probe a little bit about the sort of financial implications of what you've both spoken about, and perhaps, Julian, you could help with this. So, in Figure 1 on page 5 of the accounts, there's a sort of 4 blue boxes on the left with some 41.9 billion, I can't quite read it, so
yes,
small.
No, you're correct.
Flowing into them, of which one is NHS England administration. So I just wondered, in terms of sort of what's currently spent on NHS England administration, and whether there's sort of any estimates of, I mean, we've talked about headcount and obviously quite a lot of staffing, but more in monetary terms, you know, what sort of estimated long-term savings might be being talked about here?
So, well, in really simple numbers, we had originally set a budget for around, and I'm going to use round numbers if you don't mind, for around 15,000 people in NHS England. If you take 50% of that number out, you would be saving on a fully sort of annualised basis, when completely delivered, around £400 million. Okay. And in ICBs, they currently employ around 25,000 people. If you reduce their staff by around 50%, well, you would be achieving around 750 million pounds of savings on an annualised basis once fully delivered. I mean, those would be the sort of rough order of magnitude.
Yeah, okay, that's helpful, because obviously I think, as you're explaining, the idea is that there's more flowing down in those arrows towards NHS providers. And so I was going to ask in terms of ICBs, because again, in round numbers, it appears from this set of accounts that there was some 30 billion that seemed to go from ICBs, the money coming in, that was taken in some sort of overhead administration cost of running the ICBs, to the amount that then flowed further down to providers. So I was just trying to get a grip on, if the ICBs was a smaller administrative cost, how much more would be flowing down directly as is intended to the front line. So thank you for giving us those estimates. Obviously, that's sort of steady state into the future. We know that redundancy and reorganisation costs money. So again, I just wondered if there were any estimates at this stage of what sort of money the redundancy programmes for halving NHS England and halving ICB could potentially, what sort of region you might be in, given experience of these type of programmes in the past.
I don't have a firm estimate. This has all been sort of reasonably quickly announced this week, but our turnover rate is not dissimilar to the one that Chris described. So if you're going to reduce it by 50%, and if you want to do it mostly in this year, you're going to have to work out how about 40% of those staff are made redundant. You are best assuming that you are going to pay on average the annual salary if a redundancy package is required. And as I said, not everyone would be required to be made redundant. People will, often be, you often see through a process like this that turnover can increase. But those are the sorts of rough numbers.
I don't want to cause alarm, so I want to just really clarify something you've just said. You've said that the ICBs employed 25,000 staff, but that's 25,000 staff in total, the front line as well.
No, that's the total staff, roughly, employed by integrated care boards who are not providing frontline services. They are running contracts, doing the commissioning, doing some of the performance management. So
the 50% does apply to those.
Yes.
It implies to the integrated care boards. It does not apply to the staff who are being employed in hospitals, GP surgeries.
Let's be very clear. That 25,000 figure, is that administrators or is that somebody on the front line? So is the 50% cut coming to the 25,000? If not, how many is it coming to?
Sorry, it is 50%. So there are 25,000 people employed by integrated care boards. They are, I think I am correct in saying, not providing frontline services. So you could say they're administrators, commissioners, and the 50% applies to that 25,000.
Okay. I didn't want to cause any alarm at all, as long as we're absolutely clear. Leila Moran.
Thank you very much, Chair, and thank you for having me. To follow up on that point, Julian, if I may, so the 50% cut, is that for each ICB? Are they being asked to each find 50%? Because my concern is that there are some ICBs who are actually delivering services pretty efficiently, and partly how they're doing that is, for example, having large numbers of place-based teams and fewer numbers of other people. But also we hear overall that there is a lack of commissioning expertise overall in ICBs. And I'd be really concerned if what we end up with is a consolidation towards the centre of ICBs at the expense of place-based teams, which are often the ones who are the most efficient at delivering services. I'll give you an example. Berkshire, Oxfordshire and Buckinghamshire have already got rid of their place-based teams completely, which is the opposite of the left shift that we're hoping to achieve in the 10-year plan. So could you clarify, is it 50% for each ICB or is it a 50% system-wide change?
I will say I can't give you a lot of detail now. I mean, I was told yesterday the decision, so I'm communicating it to you. I think the detail is still to be worked through, and I think, as I said, somebody's going to have to be working out exactly now what is the relationship between not just the department in NHS England, but NHS England and integrated care boards, and what are the expectations on providers as well as integrated care boards. And I think that detail will become clear as the Secretary of State, the Department and the NHS team finalise the 10-year plan.
Is this what what are they calling themselves, the change board or whatever? Is this what they're going to be working out?
Yes, I would imagine so.
Okay. And if I may ask Professor Chris Whitty about this, I mean, are you concerned, and I think I do have a concern, that we're putting, form should determine the function. And we've got the 10-year plan coming, but not yet published. And yet we've already decided that 50% is the number. Do you have for ICBs and then for the wider teams, are you concerned that actually we've got an arbitrary number and there isn't a form that we're fitting that to just yet?
Well, I think I'm probably not the right person to ask about the way the structures within NHSE, because they are run separately, and this was very clearly an NHSE process. I want to keep separate the two processes. I can answer pretty accurately, I hope, questions on the DHSC process, which I've worked through with my colleagues and communicated to our excellent staff in DHSC. I'm not really in a strong position to do it for numbers and things in NHSE because of the separateness of the current structures.
Will the 10-year plan clarify who within DHSC versus who within NHSC are responsible for which bit? And I suppose what I'm trying to get to is, if it's a number of 50%, but we don't yet have the plan, how do we know what the balance should be? Maybe it should be a 70-30 split.
Yeah, so I think the point you make is exactly right, and that's, in a sense, the reason why I'm wanting to take this each stage as we know the facts and work from that basis. So there are two separate things in a way which intersect very strongly, but are separate. There is the process for the coming together over time of NHSE and DHSC functions to ensure there is no duplication, amongst other things. And there is a process that is separate but linked of the 10-year plan, which includes structural things like this, but also very much looks to the health of the nation and all the various components you'd need to see to improve different elements of that of the health of the nation on cancers, cardiovascular disease, and so on. Now, clearly, once that plan is finalised and announced, once the correct interaction between DHSC and NHSE is laid out, we would then, in my view, want to say, okay, the department is going to need to be a different shape to respond to that, and then we should build the structure of the department around the shape which has emerged from the combination of those two factors. I think we are quite a long way down that path, but we're not at the end of the path. And my view is that is a very strong position then to say, look, here is the logic as to why these bits here we want to preserve as they are, some bits we want to grow, and these bits we want to shrink or indeed are no longer relevant in the new environment. And there'll be quite a lot, I think, in the second area. But any organisation is dynamic. This is just a probably rather hyperdynamic period.
Hyperdynamic is a word. I've got one more question.
Yes.
Julian Kelly, it was been reported that you were going to stand down anyway, but you've expedited it following the announcement from Amanda Pritchard. It's worth saying, Chair, we've got Sir Stephen Powis, who served for 7 years as National Medical Director, that I think we should also give our thanks to. Yes. And there's also Chief Operating Officer Dame Emily Lawson and Chief Delivery Officer Steve Russell, who are also leaving their jobs. So thanks to them. I hope I can extend that on behalf of everyone here for the work that they've done. That's the entire top team. I mean, Julian Kelly, I don't know if you can comment on this, but when the whole of the top team goes, that's a lot of institutional memory that's going to. Are you aware of any processes in place to keep some of that going? And when is your last day?
My last day is the 31st of March, so in about 2.5 weeks. I would say, I think that it's definitely like a new phase for NHS England. Jim will want to bring in his team to see through both this phase of work, the closer working with the department, the finalisation, and then actually the first year of the the next year of the delivery of the 10-year plan. There are excellent people in NHS England. I mean, I just think of the teams who work for me directly. You have a huge amount of experience and knowledge. So, I am confident, certainly when I look at my own areas or even look at some of Emily's areas, that we just have some really good, experienced people who, will have that sort of continuity of knowledge.
Are their last days also the 31st of March?
I cannot honestly. I think Emily's last day is the 31st of March. Steve doesn't step down until the early summer.
That's right. And
Steve Russell, I will admit, I cannot remember.
And were you asked to leave by Sir James Mackey?
No. I had made the decision that, I've done this job for 6 years. It's been quite a grueling 6 years. We were definitely entering a new phase. And I thought it was the right time for me to step away. And with the finalisation of the 10-year plan, it was right for someone new to sort of to come in, pick up the baton, and do the next phase of the race. And I think that coincided with Amanda's announcement, Jim coming, and Jim saying, "Well, okay, I kind of want a transition team," so us agreeing timing for when I would move on.
Thank you very much. Back to you, Chair.
Thanks very much to the Chair of the Select Committee. We're obviously very pleased to have you with us. I too would like to pay my tribute to, on behalf of this committee, to Professor Sir Stephen Powis and Steve Russell. Certainly, it's Professor Powis has appeared before this committee many times. He's always been very straightforward, down to earth, and very knowledgeable. So thank both of them. They've done a great service to the health service in this country. Oh, and Emily Lawson too.
Yeah, I will.
Oh, golly, she's yes, most important. Yes. So thanks to them. All right. Right, Nestle Calliscan, please. Oh no, Clive. Sorry, Clive.
Right.
Yeah. Lucky you grunted in my ear.
I'm good at that. Right. I want to try and pursue the issue of the ICBs, and maybe you can't answer the questions, but I think we ought to at least express some concerns. We had a little discussion prior to the hearing about our view of our ICBs in our area and how they work. And they do work very differently in different areas. And I think the satisfaction of members of Parliament and what happens in their areas is very different as well. So just following up the issue, how much engagement is there going to be with the new structure of ICBs with the people in the locality? I'm thinking about members of Parliament, obviously, local councils, directors of public health, local GPs, the people who've got an interest now in seeing probably improvements and change happening in a positive way. Or is the centre of the ICB going to say, right, okay, that's it, we're going to hold on to what we've got here and everything else can go by the board? Are they going to be allowed to do that?
I don't think the vision that the Secretary of State has for, I'm going to call it the pattern and provision of healthcare, is to allow the relationships with local communities, local authorities, directors of public health, local politicians, MPs or councillors to go by the board. I mean, one of the key questions which I think the 10-year plan will answer is, what is the right approach for delivering a neighbourhood health service centred around high quality, effective primary care with integrated multidisciplinary teams, sort of wrapping around local GP services to in fact strengthen the relationship with patients and their communities. And I think one of the questions that the 10-year plan will resolve is, how do you play the role of ICBs as strategic commissioners? And what responsibilities do you see providers, could be GPs, it might be other organisations, taking on for commissioning local care, and actually, as I said, like strengthening the direct link between providers, local communities, local authorities. And I think that is one of the, I mean, I cannot give you all the detail here, but I think that is one of the things that will emerge out of the 10-year plan.
I understand that. I'm just trying to put a marker down for things that I'm worried about could be lost. And it follows on what Layla Moran absolutely said about the place element in ICBs. When ICBs were set up in Sheffield, obviously we look after our own areas and we understand them. We as local MPs fought very hard indeed, along with the local council, to keep a place element to the ICBs, a Sheffield place element, because the working relationship between the NHS at that level and the council director of public health is brilliant in Sheffield. It works. It worked through COVID. You know, everyone feels confident and positive about it, and therefore to take that element away, that level away, and suddenly think you can do everything at a higher level, more central level in the ICB, would actually destroy the push that's going on. It's at that place level towards a move to community care, move to equalities and looking after the poorest areas, a move to prevention. That's where the drive is, at that level, and I just don't want to lose it.
Rather than me respond to the point, but I think is to take the input and I'll say into the thinking that is going on. That is completely understood. I do not think the intention is to weaken the links between healthcare provision, commissioning and the local people that you have just talked about.
So firstly, I recognise all the points you're making. Secondly, not every ICB works. Not only do they work differently, some work more effectively than others, let's be honest. Yeah. And so I get herograms and the reverse from local residents, senior leaders and indeed MPs from areas who know their patch. But that's true, of course, of the NHS and health services as a whole. If everything could be as good as the best, it would be a different situation. And a lot of what you're trying to do is make sure that everything does move as close to the best as you can get. I think some ICBs were set up in an easier way to succeed, and that worked in particular where the geographical limits of the local authorities, the geographical limits of the NHS, so in a sense the political and administrative boundaries were similar, and when they were a size that was sufficient to produce additional scale but not so big that they were unwieldy. Now, I don't want to go through a list of which ones are which. I think that would be inappropriate. But I'm just making the point that I don't think... But on the other hand, I don't think there is any intention from certainly the Secretary of State's sort of philosophy to take things from the periphery to the centre. In fact, I think, if anything, his tendency would be the opposite direction overall.
As long, I think right. Obviously, Julian, you can't make the commitments now because you won't be there to see them through. But perhaps the message could be passed through that there has to be a requirement to actually engage with the stakeholders at local level, including MPs, but councils, directors of public health, local GPs and others, about how they think things are working and how they want to ensure the best of what's working now carries on in the future.
Yes, of course.
I can't emphasise too strongly what Clive Betts has said. These local connections are so important. And if I was sitting this morning as chairman or chief executive of the Gloucestershire Integrated Care Board, I would be really scratching my head saying what is going to come down the line. So I can't emphasise too strongly that the sooner you can give answers to those questions, and particularly that these people have local connections. They're locally embedded in our communities, and they will be really interacting and worried about what's going to happen.
So let me just say I completely understand, and I will absolutely take the feedback and the strength of it.
Well, I think I'll go further. Actually, we understand and agree.
Yeah.
Yeah.
Great.
Yeah.
Yes, that's really helpful. Nestle Calliscan, please.
Thank you very much, Chair, and can I just thank the panel members too for their contributions so far. I want to ask just to build a little bit more on Mr. Betts' points around place-based. As an ex-council leader of 6 years, I absolutely concur with what other panel members have said around the importance of footprints aligning, and that's more of a technical point, but also how ICBs have examples across the country where they are working excellently, but agree with you, Professor Whitty, there are some that are quite dysfunctional, to be honest. And so as part of the efforts of whether it is restructuring of NHS England or the department, through an effort, it seems, to redirect monies to the front line, we mustn't lose the very good practice, but make sure it is also an opportunity to improve those areas that are being let down. And they are quite often areas that are already badly served in terms of health outcomes. And that will be news to nobody on the panel, I know, but I thought it was important to say. Specifically on footprints and localisation and that place-based approach, there are two things I wanted to mention. One is prevention work, and I'm looking for some reassurance that as we embark on what is a major agenda for structural change, that commitments around prevention are not lost, because ultimately in the long run that is what has the biggest impact on health outcomes, and work of local authorities as part of that. And the second is around the work the government is leading on devolution and footprints that will emerge from that work, and some reassurance that those two things, that somewhere in the system people are speaking to each other and we do not end up with a mismatch of 100 different footprints that mean very little to populations or, for instance, council leaders. And then I want to just talk about staffing numbers, if I may, but if I go to the panel.
I'll do those two first, because I think they mainly come to me, but both Mr. Kelly and actually Dame Jenny may want to comment, because Jenny worked in local authorities for much of her career and fully would agree with that. Yeah, I'm the Chief Medical Officer as my main job. You'll be unsurprised to learn I 100% agree with you on the prevention, and indeed I would like to go further on prevention. My view is it is strengthening the prevention that we need to do rather than weakening it in the next phases. And if we wish to make the NHS sustainable in the long run, as well as improve the lives of our fellow citizens, shortening the period of ill health is the only way we will do that, and the only way you can do that is through prevention. So I completely agree, and ICBs and local authorities both have a very major role. I think in terms of your first, so I just want to reassure you that was completely my view, and I don't think that Secretary of State would in any way disagree with the points I've just made, but I will put them with as much topspin as I can give. On your second point, some ICBs, I think, are set up in a difficult way, and the ideal situation is where there's a proper balance between the political structures around local authorities, which hold many of the levers, particularly on the prevention side, but not only, the secondary care, so there are some secondary care providers, primary care, community care, and wider systems, including and very importantly, including charity, third sector, and other providers who provide a lot of the stuff on the ground. Many of in my view, the two situations where predictably ICBs are not functioning as well as they should do are either if the leadership is poor, that's true in any organisation, but the other is when those get out of balance. So if an ICB becomes, for example, almost entirely dominated by one secondary care provider, one hospital, that is going to lead to trouble. Because that means that the other bits of the system, which all have to interact, don't work as well. The same can go in the opposite direction. So it is making sure that the different elements are combined in an effective way. And I think there are good examples of this, as the committee have said, and some less good examples scattered around the country. There isn't a complete predictability about this. It's not just, all the good ones are in areas of affluence and all the poor ones are in areas of deprivation. That's absolutely not the situation at all. If anything, the correlation might go the other way. But there is definitely, it's much more to do with these kind of factors. I think all of us want this to work, and I don't think anybody, certainly on this panel, would in any way backtrack from any of the points you've made. So I think, can I just check with Dame Jenny and Mr. Kelly whether they want to add?
So I may come in if that's okay. So as Chris has said, actually I spent more of my time as a Director of Public Health, and in fact I came in as Deputy Chief Medical Officer actually on the health improvement and prevention front. So absolutely support the comments that have been made. I think actually we can use some of the work. I'm now working in health protection. If we think about these changes, I actually see great opportunities. If we take something like vaccination, if we don't get the system interoperable and vaccination rates drop, for example, we have a role in all of the oversight of all the national immunisation programmes. NHSE has a key role in the delivery, but actually people will not come forward unless they have long-term trusted relationships with local services, often voluntary services, or religious leaders, or whoever that might be. So the opportunity to shift the focus, I think, to prevention and local is a really strong one I would support. From my own organisation perspective, we have 9 regional teams. We have specified consultants in communicable disease control. They work with the Director of Public Health. I was in Leeds the day before yesterday with colleagues from the Council, with the Director of Public Health, and so we will be looking to absolutely maintain and strengthen those arrangements.
I mean, I've nothing to add and would completely concur.
Thank you. May I just ask some questions around staffing numbers?
Yes.
Thank you, Chair. It is true, isn't it, that in recent years the Department of Health and indeed NHS England has seen a significant growth in terms of staffing. And if you take, for instance, the department, there are tens of new recruits every month. So the very fact that it has been agreed that there will be a freeze, as Professor Whitty have already said, in of itself will create an immediate saving. And also the right thing to do in the context of what might be redundancies in the coming months. Any sensible organisation would do that. But I want to ask, my first point is, in the context of frontline services being at a breaking point, and chief executives of hospitals, for example, frequently talking about staffing issues, budgetary issues, appointments not being able to be met because of resourcing challenges, the public, you'll understand, will be surprised, to say the least, to hear that there has been such an increase of numbers in the Department of Health and NHS England, not in terms of frontline healthcare provision, but what they would describe as backroom staff. That isn't to diminish the important role that these civil servants or NHS England staff, and I should say a long time ago I did work for NHS England in the health inequality team, but actually from a patient perspective, the fact that they can't get an appointment, it is difficult for them to accept. You may or may not want to comment on that. I wanted to ask about the freeze. The first is there an immediate understanding of what savings the freeze will create? And have any decisions been made about what that immediate saving will be used for? Will it be used to just close what is an existing gap in the finances, or have any decisions been made about redirecting that as it stands to any frontline services? And
sorry, can we just sort of speed up the question a bit?
That's fine. I think that will answer my secondary question anyway.
So I'll answer the first bit of that, May Chair, and I'll pass over to Mr. Brittain for the second bit on the numbers. So on the first one, I would both like to, in a sense, agree with the first bit of your first section and challenge, not to you, but challenge the perception on the second, because I think there's a misunderstanding on these things. On the first, it is true that the department grew, and it grew in two waves. A wave that was associated with the Brexit point, and particularly where there was a concern about a hard Brexit, what was that going to do to drug supplies, a variety of other issues. And the anticipation was that would then retreat as we went through that period of change, but then COVID hit almost immediately afterwards, and unsurprisingly the department grew very substantially during COVID, and I don't think anyone would expect anything else. It then shrank again, quite a long way actually, but there was a creep up before the election, and then quite a lot of people came in after the election in response to the priorities of new ministers, and that happens in most situations. Nevertheless, new ministers were rightly not at all in favour, and rightly not in favour, of increasing numbers, and they wanted the numbers to go back down. They were clear about that, and that's the reason why we started in the initial headcount stop that we're talking about. So, yeah, that is a mathematical fact, but I don't want people to get this out of proportion, and I think that I want people to understand the reasons for that. But I think we're all agreed that the correct direction of travel is down. Now, on the other hand, however, I think there is often a very misleading impression, both of what actually frontline means and of the scale of the numbers we're talking about. So the department that I have the privilege of being part of when I'm in this part of my job is around about 3,600 people for the whole of the UK. Sorry, the whole of England, to be clear, before I get my other CMO colleagues point out how wrong I am. Whole of England. I also work as a doctor in UCLH, which is well over twice as big as one hospital in terms of the number of people, and some of the bigger trusts, like Guy's and Thomas, is many times bigger than that. So actually the department for the whole country is a lot smaller than a single trust. So the idea that this kind of behemoth, the NHS is a huge organisation, of which these organisations are really relatively small. That does not in any way invalidate the point they should go down, but I don't want people to get these things out of kilter. And the other thing is, within that, there are people, for example, who are helping to do public health across the wider system, who are helping to make sure we have research for the future. These are the things which are actually going to mean that health improves in the long term. So a lot of the research, the largest research organisation in Europe is run out of the Department of Health. Are those people frontline? I would argue you could say they are, but they're counted in this sense as back office. But actually, if you want new drugs, you want new vaccines, you want new hip replacements, those are central people. So I think there's a real misunderstanding, and I want both of those to be held to be true, that what the department is doing really affects the front line, and I would extend this to NHSE as well, but also that we agree that the numbers should go down. But that I just wanted to make sure those were in balance.
Really helpful. I'm sorry, and then let's cut you off.
Do you just want to come back on the numbers?
I would, in terms of the savings.
Yeah, very briefly then. So if we assume there's 3,500 people in the department, I'm using round numbers again, and 7% natural attrition from their headcount cap. That's also the headcount, the recruitment restrictions that have been put in place. That will equate on an annualised basis to about £15 million a year. And that money will flow. That money will flow through to the front line.
And just to add 2 points to that. For the first year, half that, unsurprisingly, because it happens over the whole year. Mm-hmm. And the second point is that if you're doing voluntary exit schemes and other forms of redundancy, if they were used in other periods, voluntary exit schemes, you don't get any savings in the first year. In fact, you usually spend more money in the first year. You would expect to get savings somewhere between 6 and 18 months afterwards, depending on the particular scheme that was used.
Chair, if I may, could I just add to Sir
very briefly, Julian, because we've got an awful lot to get through.
Just to support the position. So, as a new agency, of course, we didn't have a history, and we have downsized from 18,000 staff to 5,500 completely downwards. and actually pushed. Again, we have frontline laboratory staff. 2,000 of our 5,500 are actually literally working next to NHS colleagues. So I think this understanding of what's sitting behind the numbers, as we started with, is a really important feature.
That's very helpful.
Chair, can I just say one thing, which just to avoid us having to dance around something which we have been slightly dancing around? The Prime Minister has just announced that he is intending for NHS England and the department to merge over time, so not just a bringing together but an actual full merger, and I just thought it was important that you were aware of that.
I think context. The subtext of this, most of us were expecting that. Yes. Yes, so that really adds another complexion to it. Can I just say one thing very briefly to you? We haven't got onto the accounts yet, but Nez will let us into that with prevention. The only bit that I can find about prevention in the accounts is a very short paragraph on page 79. I don't want a long answer to this. Can I simply say, given the interest, certainly in this committee, the Health Committee and Parliament, about prevention, could we in next year's accounts have a little bit more importance paid to prevention?
Yeah.
That's very helpful.
Obviously it's one of the three
I've got 2 points for both either Sir Chris or Julian, and it's this. Both of you have actually acknowledged all these place-based and local contexts and local all of that in the ICBs. But you've been at pains, Chris, and I totally agree with you. There is a lot of difference between the best performing ICBs and the worst. You've put a sort of blanket number on this 25% cut in staff on for ICBs. If I was chairman of the Gloucestershire ICB this morning, or the chief executive, I would be saying to myself, am I up at the top there or at the bottom, and what effect is that going to have on me? So how will this be negotiated with the individual ICBs as to what their cuts should be, and how are they to be encouraged to inform to perform better from the bottom to the top?
Well, firstly, I didn't put a number into this at all, I don't think.
Right.
I've deliberately avoided doing so. But on the second, as things stand, and I realise that Chair apologises to me in a sense abusing the committee by saying this, but many of our colleagues will be watching this.
Yes, of course.
I want to be clear that as of tomorrow, everybody who is working in NHSE and DHSC is doing the same job as they are doing today. And at this point, ICB, the line of sight is absolutely between ICBs and NHSE, and that will be true tomorrow as it is today. In the long run, that of course will move more closely, but therefore Mr. Kelly may wish to comment more. But I think your point, in a sense, I think we all agree with, which is we would all want to take a look at each ICB in the round in terms of the decisions that are taken next, but those are not going to be taken, in fact, by any of the people sitting in this line up here. So it's probably sensible for us to kind of stop at that stage.
That's really helpful, Chris. I have one more question, then I'm going to take a break, because I hope we've sort of got perhaps as far as we have on this reorganisation point this morning, and we want to get into other bits in the annual important accounts. So in a sense, probably this may be for you, Julian Kelly, but maybe for others, I don't know. To what extent are you liaising with MHCLG in relation to local government reorganisation? Reorganisation in health, clearly, as Clive has made clear, has a huge impact on local government, and local government delivers this local public health and many other functions.
We are liaising with MHCLG, indeed with and through the department, precisely to make sure that the devolution agenda that is being pursued through MHCLG aligns with the direction of travel, and indeed, as I said, whatever conclusions are reached as the 10-year plan is finalised.
That's sufficient.
Yeah. That's sort of been a fairly momentous morning. So what I'm going to do now is take a little bit of a break to give us all a bit of a breather to clear our minds as to what we've all heard this morning. So the clock currently stands at 11:02. I would suggest if we could try and be back here by 11:10. I'm sure there will be little groups of meetings going on. Just be wary that there are microphones open. So just be careful what you say where. So I'm going to now call for a break and say order, and please. Well, thank you for that earlier session, a really interesting session which raises a lot of questions, I think, but we've at least got the gist of it all now. So I think we now want to get into what we originally were going to do, which was the annual report and accounts, and examine bits of that, if I may, probably the easier bit of the session, really, in a way, because there is some certainty in that. So I'm going to come straight to you, Professor Dame Jenny Harries, please, if I may, and talk to you about the UKHSA accounts and ask you what steps did you take in 2023 to improve your accounts and remove the CNAG's disclaimed audit opinion.
Well, I think these interventions I'll describe have clearly been beneficial because we have had that disclaimer removed, and I think we're on an upward and steady trajectory, still with lots more work to do. We have been working very closely with DHSC colleagues and particularly with NAO and with GIAA. We have been putting in a timed approach so that we have very realistic timescales and we can escalate up very quickly, so we're looking forward to do that. We have looked very deeply, I think, at the accounts and some of our processes, and we have been using some third-party assurances, both to help the process of the audit going through, so it's an easier audit for NAO to deliver in a time frame, and it gives us assurance that we're doing the right things. And of course we have particularly addressed in quite a lot of detail the issue around the CVU model, which I might say, whilst it's caused a number of problems over the accounts, there has never actually been a problem with the model itself. It was a good model and it predicted well, but it was the governance around it which I think was the problem. And so to answer that part of your question, we have made more robust our governance processes. We instituted a financial control programme. We have just revised that actually because we've been making progress and we're refocusing it in phase 2. We have ensured our governance processes are strengthened, and that includes, for example, I oversee personally, have been overseeing the Financial Control and Improvement Board, but of course there is now a very, very strong and challenging arc to which our programme goes. And I think on top of that, which we might come to, and it partly relates to the previous conversation, I have restructured the organisation completely at the top level. So we've taken out a number of staff, we're much leaner. We now have a very tight top level. I have myself and 4 DGs with 4 groups, and I have a new Deputy CEO, COO joining us very shortly, has been announced.
So do you want to just say a little bit more about that restructuring, number of staff and who does what?
So it was a focus. I mean, if I just go back to what I said before, we were an organisation, you alluded earlier to the fact that we have had quite a complex birth, and it kept changing mid-year, which is one of the lessons I think I have learnt in this process. But so we started with 18,000 staff. I believe we did the biggest, not just people, but financial reduction in a single year in the civil service. So we went from 15 billion down to 3.2. Our staff went from 18,000 down to 6,000, and then subsequently on to about 5.5. So our total number of staff we've reduced down. The important thing, though, which goes back to form following function, is that we have the right quality and quantity of the right sort of staff. So what I've done with the restructure is the things that we do deliver frontline staff, process. We have emergency responders, for example, on the collision that you may have seen in the North Sea. Perhaps not something you'd think about our agency, but actually our staff are advising on the public health impacts of that. So we have staff in a number of specialist areas, and what we've been trying to do is actually boost the number of staff in the areas where there have been historic shortages in some specialty areas, but then actually make very lean the sorts of pure administrative functions, and get those into a very tight and governance shape. And I think we are just about there. We implemented it. We did the formal consultation last autumn. We've implemented it very quickly. So from 1st of January this year, and there are a few people still rolling off towards the end of this financial year.
So Chris, what we're trying to do this morning is to put certainty onto an uncertain situation. Given that scale of reorganisation, do you think that UKHSA is now in a state that it would be fit for the future and will not need to go through any of the more radical restructuring that your department and ICB's and Julian's NHSE is going to go through?
Well, I think I'm going to hedge, Chair, largely because there's a new, for two reasons actually. The first of which is there is a new chief executive coming in following Dame Jenny, who's done an absolutely stellar job, I have to say, in an incredibly difficult time. And I think what you've seen is an organisation that has shrunk in size, has balanced the books, and has defended the UK from COVID and multiple other threats, as she says, just in the last few weeks. So I think it's been a great organisation. But the two reasons I'm hedging is partly that, and partly actually because it's the bit of the system that is most amenable to have to either scale up or scale down depending on the threats that hit the UK. So the number of people who will have heart attacks or hips is pretty predictable year on year. The actual need in terms of health protection is much more variable. So I would not see it necessarily as something which is static, even just in terms of the actual need for the population. But certainly we would want to give, and I would want to give, and Dame Jenny would want to give her successor the opportunity to sit down and actually think what they want to do before we have prejudged exactly where they get to, obviously under the overall leadership of the Secretary of State.
Really helpful. I echo Sir Chris's remarks about your achievements. I did echo that at the beginning, and so we do recognise that. So on top of all this restructuring, you had to get your accounts in order. You relied quite a lot on external consultants to help you with that. And by the way, congratulations on getting from a disclaimed account to a qualified account. What we now want to see you get is from a qualified account to an unqualified account. So we'll be coming on to questions on that in a second. But so on this external help, are you able to tell us how much that cost?
Yes, I can. We have had a mix over inherited from the start of the pandemic, or when we came into being, where we had very significant costs on external support, which somewhere around 230 million, I think. Last year it was 1.04 million, and there are reasons why we do that. There are a number of areas in the organisation, partly because of of what we do and what we've been required to do in a short period of time, and partly because getting the accounts to past a disclaimed state was really important to me, to make sure that the organisation was in a solid, stable position going forward. So we have used that additional resource not simply as extra finance people. It's very much to assure that we had assurance on areas. So if I mentioned the CVU model, which caused some degree of consternation in our accounts, we have actually used external staff appropriately, I think, to assure the model. So these were expert modelers looking at that model, providing assurance both to myself and EXCO and to our own ARC, and I think in turn then providing additional assurance then to NAO. So I think we are using them selectively and appropriately to move the organisation forward. At the same time, we are strengthening our own financial team, and I've seen that come through during the year. And I think the other important thing is actually it's not simply about the finance team. It is very much how does the organisation understand what its responsibility is. And when you look at our accounts and some of the hard work that's been involved, I would really like to recognise the work of our finance teams and the support that we've had from Department of Health colleagues. We've used them to assure the processes are as efficient as they are, but often what we are not doing yet, partly because of our history, I think, is making sure we get things right first time. There is absolute consistency that we're doing things upstream. It's a bit like the prevention agenda, actually. We've moved our accounts forward 6 weeks in laying them. We are on time to do that again. They should be in October for this year. And then I hope for the 25-26 accounts, again with a plan there, they should be in a non-qualified state and laid pre-recess, I hope.
So you're not confident that this year's accounts 25-6 are going to be regularised and without qualification.
So I think, and Andy may want to come in, but I think we are actually technically unable to do that because of the closing account and the issue of the CVU previously. So what you, I think, saw the first year was we put a lot of work in to get the right basics. You saw that move in the second year, and then we had the CVU issue. But because of our closing accounts and the impact that has on the different account streams, we're actually unable to do that for next year. I mean, I think when I was here probably 2 years ago, I think I did say it's going to probably be a 3-year forward look on this, and I understand that actually with disclaimed accounts that's not an unusual trajectory to get to that point, but we are certainly aiming to be there for 25-26, which I think is the earliest date that we can do.
Thank you very much. That's really helpful. What assurance can you give us that you're addressing the government's internal audit agencies' concerns about the lack of effective decision making by the executive committee?
Probably partly answered that question for you. In fact, at the time that GIA did that review, we were already planning. It was running side by side. It was in parallel with the proposed changes. We had, I think one of their concerns was particularly around a programme which we ran called Building for Ambition, which I think was slightly misunderstood because in many ways what we were trying to do in quite a novel way was test out what the structure and the system looked like from the people in the middle using them. So it wasn't a formal programme, and it was intentionally designed loose, if you like, to try and get a picture of how we could practically change our decision making and make it slicker and faster. We've then gone on to formal consultation and reorganisation I've just described, and as well as taking some, making a much lighter top team across the organisation. One of the main purposes actually was to get the decision making faster and with the governance appropriately, and we now have fewer boards. We did a complete review of all of our boards. The expectation, and there is a leadership element of this, is that our directors and our deputy directors get the opportunity, which I think they were saying they didn't have before, of being decision makers, driving and building a new organisation and really feeling part of it in quite an exciting way, but also the responsibility of doing that as well. And so the way ExCo is functioning now, we've changed our meeting dates. We meet twice weekly. We have a workshop in the morning to focus on strategic issues, and our papers are now completely altered to make sure that they are strategic in intent, and that we are effectively providing the governance and the guide rails for people a little bit further down the organisation to be making the day-to-day decisions, corporate decisions, and taking them forward. And we're acting as the check and guide to that, which I think is much more appropriate, but it also signals, I think, the maturity of the organisation.
What changes have you made to your governance board to make sure that your organisation continues on the upward trajectory that you're projecting?
So, as we have restructured where the governance team report into, so they report into my chief of staff. It's coming into me. We've refashioned various other areas of importance. So things like our strategic risk register has been completely reviewed. Our performance indicators also have matured. They can be quite difficult to get good indicators, but on some of the areas, if you take something like vaccination, where you are part of a system, but nevertheless we're challenging ourselves to give quite hard KPIs on that so we can see where we are on track or not. We've implemented some very deep searching but quite broad controls for each of the Director Generals. So I meet with each of them looking at the trajectory for their financial trajectory, but we also include our HR components of that as well, and have our business partners HR. And so there is a whole new system of catching things early, if you like, challenge early, and then a formal governance system going above.
That's Very helpful. Anna Dixon, please.
Yes, thank you very much, Chair. So you mentioned earlier the abbreviation CVU, COVID Vaccine Unit, which obviously has been responsible for the procurement and distribution of our supply of COVID-19 vaccinations. Can you just tell the committee what the future of that unit is and whether it's remaining within the UKHSA?
So the origin of the CVU was part of the vaccine task force, which people will probably remember from the pandemic, and it did some brilliant things at a time of great uncertainty. So it had very fast logistics. It was working with different pharmaceutical providers to ensure that we had the right vaccines in the right place, and we were continuously monitoring the virus and getting the right vaccine for the population. However, that was one vaccine for one disease, and of course actually the other half of the organisation, if you like, had always routinely been doing all of the other immunisation programmes, evaluating them on a routine basis, working to support JCVI, the Joint Committee on Vaccination and Immunisation. So what we've tried to do is take the best of the vaccine task force and also revamp what has been quite a historic part of predecessor organisations in the what was VCR, Vaccines and Countermeasures Response Team. We have now moved them into a new team, which is sitting under our commercial director. That allows us to get best value out of contracts, but working very much with the response, so we can do what I would call steady state vaccine programmes and just-in-time vaccine programmes, and makes us much better prepared then to respond to a pandemic, but also get better routine value. So the short answer to your question, having gone around the houses, is we now have a single unit, and I have to do my own acronym for this. So it's CVCD, which is the Commercial Vaccines and Countermeasures Delivery Directorate.
Okay,
it's
a bit of a mouthful.
It was literally launched last week.
Yeah, CVU was a little easier to get your mouth around. So obviously the unit and now this new organisation holds contracts for vaccines that we actually don't expect to use. I understand that these are non-cancelable contracts. So how much sort of money is locked into these contracts that we can't get out of, and indeed how that relates to the partnership with Moderna?
So I would take those two things separately. If I go back, there will be different values for different vaccines. So each year, for example, with let's say childhood flu vaccines, you'll see in the accounts that there was some loss on that because of flu vaccine is usually an annual vaccine, and you will never predict precisely how many children are going to take that vaccine up that year. You don't want to have too little in case people come forward, because we can create health benefit. Equally, you don't want to have too much left if people don't come forward. So each year there will be some components of that in the budget. The big, if you like, losses in the budget relate to contracts for COVID vaccines, yes, which were taken out prior to UKHSA coming on board. And I think this is difficult because it clearly looks like a loss of resource, but I'd say two things. One is and I think if, commentary into the public inquiry has shown this very clearly, if you have an unknown pathogen and a significant harmful impact for a whole population and its economy, these are relatively small amounts of loss. So I think on the COVID vaccines, it's around $1 billion, which sounds a lot, but if you put that into a context of 300 billion spent on the pandemic, it's a relatively small amount to maintain the protection in a context where it's almost impossible to predict. Now, having said that, I think the overall loss there is around 1.7 billion on COVID in the accounts. Actually, what the CVU, now our new team, was able to do is actually always try and maximise the benefits. So by adjusting contracts where that was possible, or extending shelf life where that has been possible, clearly only with the right safety guards, we have actually managed to push forward and save 2.4 billion. So some of those vaccines have been used for the autumn campaign,
They're not all out of date, and
they're not. They will start
wasted.
to come out of date as we go forward into the next year. So there are still some there being used, but clearly we need to make sure we're using the right vaccine for the right variant, for the right population.
So how is your new team going to make sure that they get value for money in the way that they're going to be procuring, entering into contracts, predicting the volumes, so you don't end up with these sort of situation that we've got here of £1 billion worth of vaccine underused, let's say, rather than unused?
There's what we do routinely, which I'll come to, but I have just given an example of where that team has been working to ensure that where there were contracts in place, which were there from the pandemic, we actually maximise the benefit of that, where it's
sort of avoiding this situation in the future is more.
Well, I mean, the only challenge I would put back is if we had another pandemic, I would rather have an excess of vaccines than none at all, and I think that is actually what the Vaccine Task Force did and has been praised for doing, because it ended up with sort of 10 shots across the system and success all round in a way which, or more or less all round, in a way which was perhaps not predicted. We expected more to have failed. So I think if we have something as significant as the pandemic we had, we should expect this sort of variation if we are protecting the population. What we do routinely, though, and this comes to your point, is for something where we can predict a seasonal pattern or a virus which has a settled cohort of the population that we would normally, we know will be protected, that is all planned out in advance. Every time a vaccine is approved, is recommended rather by JCVI, it sits on a background of epidemiological evidence, clinical evidence, and importantly cost effectiveness evidence. And they are continuously reviewed. So again, people, as contracts come up for renewal, the commercial team will check those as well.
Can I just pick up, and it may not be you, Dame Jenny, but perhaps for Chris, is the sort of PPE, as we're on COVID, and obviously here in the accounts it lays bare really the, I would say in this case, waste of taxpayers' money. You may argue as well that there was some of that which was unpredictable at the time, but with I think £10 billion worth what they call here impairment and write-down charges. So I wondered if you might just speak really to the sort of PPE stockpiles, the sort of costs of the poor procurement that was entered into historically, and sort of where we are now, and again how we prevent such issues arising in the future.
Well, I'll do the front end. Mr. Brittain may want to come in and do some additional points. I think to acknowledge also this is a pretty complex area of procurement, and the current COVID inquiry is going over this over some weeks. So, in a sense, I'm only going to give a very small comment on really quite a large area. I think it's worth casting our minds back to where we were in the early part of 2020, and there were two things that were clearly true, in fact probably three. First of which was we had a precarious, and at a local level worse than precarious, supply of PPE overall, and I think you heard the very moving testimony from healthcare workers over the last years. That was a situation the government, I think rightly, said it absolutely did never wish to see again happen during the pandemic. So there was a very strong push to do this. Simultaneously, we didn't have a vaccine at that stage. We didn't know how long we were going to have waves that were going to need this protection, and this could have gone on for some years. At that point, professional scientific view was 2 years, if you're lucky, and maybe no vaccine at all. Remembering the last big pandemic we had, HIV, on that scale, no vaccine still, some decades later. And thirdly, that these waves could also hit the big suppliers like China. And if they had that, they would, as most countries would, use up their own supply before they actually export. That put lots of areas of uncertainty into a market that simply wasn't designed for the degree of international demand. Now, the result of that was some degree of over-ordering, and I think there was probably also some belief that, well, if we've got it, we can then keep it for the next pandemic, and I think that hadn't probably been thought through as fully as it could have been. Now, alongside that, there were some issues where there were people who, the most generous interpretation were in a field they didn't really understand and were procuring things that weren't of the highest quality, and in some cases gone beyond that. Some of those are now legal cases, and I can't go into them, but I think it's clear what I'm saying. I hope it's clear what I'm saying. So I'm not saying that even it all falls into the understandable under the circumstances, but I think a lot of it was understandable under that degree of uncertainty and with that level of risk to staff, which I think none of us want to see repeated. In terms of the accounts, I think it's important to recognise that most of these have been, in a sense, put into the accounts previously. So this is not a new information that's in these accounts. But Mr. Brittain may want to. Andy, do you want to?
I mean, that's exactly right. This is we've discussed this sort of at the previous committee hearings on the accounts. The actual change in the numbers is very minimal this year. What I would add is that the sort of disposal programme is now completed, so we are now completely back to, we've sort of dealt with all the legacy COVID excess PPE stock, and we've now just to the residual core of what we need for future what we consider we need for future pandemics. We have disposed of the PPE in line with the government's waste hierarchy, which sort of is recycling first, then recovery through energy from waste, and then landfill, and we haven't put any to landfill, so we've got rid of it in the most appropriate way possible.
But quite a lot of PPE is actually used under routine circumstances in NHS. Yeah. Things like gloves and aprons and face masks are standard.
But, as the account itself reports, some of it was unsuitable for use, and you're saying all of the effectively dud PPE has now been disposed of as we sit here. So on the point of, obviously we've spoken about vaccines and how you can predict better. So what are the plans for how you're going to estimate the future PPE stockpiles to help for resilience in the future against future pandemics?
I think there are certain things which in any pandemic stockpile are going to be needed virtually whatever form of pandemic you get. So gloves and aprons, I would have thought, are basically a universal thing you're going to need under all circumstances. But just taking the example I gave of COVID, of HIV. I mean, HIV is a sexual transmitted thing. You never, masks are irrelevant. For example, visors only useful for particular kind of procedures. If you had a vector-borne disease, virtually all of these things are irrelevant. So I think the route of transmission does, to some extent, define this. And I think people assume you can just have a PPE stock. The basics of it you can have, but what you will actually need will depend on the disease and the route, particularly the route of transmission you have. That said, our aim is to have a longer lead time. So I think what we demonstrated was we just kind of made an assumption that you could buy in from the international market. And if you have an epidemic, that is true. So if you had if this had been something that affected just Northern Europe, there would have been no problem actually buying in on the market. But in a pandemic, everybody wants it simultaneously. So you therefore need to have, in my view, at least 4 months worth of maximum use PPE available in the country. That's my personal view, which buys you time then to be able to actually work out how you want to respond in terms of make or buy.
And sorry, in your own risk assessment, I believe you've said that respiratory, though, is the most likely. So are you making provision for domestic supply in future of specific types of PPE, recognising that it's obviously could be any of the mechanisms of transmission? So
the basics of gloves, gowns, aprons, masks and visors in different numbers, to be clear, so many more gloves and aprons than you'd have, for example, visors. It's going to be likely in the majority, not absolutely all, but the great majority of pandemics or major epidemics we can face. Andy can probably go through some of the numbers of where we are at the moment, but what we should aim to do is actually have the capacity to respond not to a full pandemic. That would require an extraordinary cost in storage, but for the first 3 or 4 months to be able to actually scale up and buy yourself time to actually have a full spectrum response.
Probably enough detail.
I'm going to ask a question I've asked before in this committee, and you hinted at it in your answers, Chris. Part of the problem with both PPE and vaccines, and indeed a lot of other equipment, is it goes out of date. And there seems to be an attitude in the NHS that we'll wait till it goes out of date and then we'll dispose of it, burn it, basically. Why is there not more thought, as it's coming towards going out of date, of either finding another market for it or even necessarily give it away. I'm sure a lot of people could use this equipment, but just to actually burn it does seem to be an awful waste.
And I think, if I may answer, I think there's two things here. With the size of the original pandemic COVID stockpile we had, we did look at things like that. We looked at giving it away free, and in fact we had a free PPE scheme up until I think the 1st of April 23, or maybe 24. I'd need to check on that. But we did have a free scheme. We also did look at donating to countries. We exhausted those routes before we resorted to the waste hierarchy and using energy from waste, as I mentioned. So that was with the COVID legacy stockpile. With the what we've got now, so the current pandemic stockpile, I believe, and Mr. Kelly may have more detailed information than me. With the it's run by SCCL, part of the NHS, and they are looking to move to more dynamic stockpiling to do exactly the sort of thing you're talking about. So it's not allowing things to go out of date, it's getting stock in, holding it, and then shifting it to use in the NHS wherever possible. So to avoid exactly the problem you've mentioned.
And just one important technical point, nowhere accepts as donations things that have only got 2 or 3 months to run, because it's only possible for them to use it. So actually it costs them more than they benefit. You've got to give them a long enough run at it.
Clive Betts.
Yeah, just a couple of issues. Just coming back to the COVID stockpile, the vaccine stockpile you've got. I was surprised. I had my COVID vaccines on a regular basis. I'm immune compromised, so I get priority as other people do in that situation. I was had a brilliant service. Went to the Woodhouse Pharmacy recently. Gone to different places. This time when I went, in the past my partner's always had entitlement to a vaccine as well, on the basis that if he catches it, then it passes on to me. I'm immune compromised as a concern. This time he was told, no, it's been changed. Can't have it free. But you've got all this COVID there, vaccine sat there doing nothing, but you're actually reducing the number of people entitled to it. Is that logical?
Well, it will be for each individual vaccine and cohorts and the cost effectiveness. I mean, each of the programmes for something like COVID or flu is reviewed on an annual basis.
Yes.
They are independent recommendations by Joint Committee of Vaccination and Immunisation, and although UKHSA will gather all of the scientific evidence sitting behind it, it's JCVI which makes those recommendations, and they will look at what the likely impact, beneficial impact or harmful impact is for individuals in different risk cohorts, in different age groups, and that's why you'll see for each of the national programmes a different effectiveness. I mean, obviously with COVID, when it started off, it's changed hugely in terms of the impact it's had, even for those who are immunosuppressed. If you have had a vaccination, you're very likely to have developed, either have had COVID itself already, or have developed some immunity from the vaccine. So all of those things are looked at, and for the reasons which I was just explaining about making sure we are cost effective and use public resources effectively, those cohorts are defined with that benefit in mind.
Could I just add 2 points which are clinical points? One of which is we are much more confident now that people who are immunosuppressed are protected by the vaccines than we were. But secondly, the virus has changed. And initially, vaccination gave quite a lot of protection in terms of transmission. The current versions of the Omicron sort of subsequent variants, although the protection for the individuals vaccinated is still very strong for severe disease, the transmission reducing potential of the vaccines has gone down quite a lot. That's a function of the virus. It's not a not a function of anything else.
Thank you for that. That seems a very logical response to something that, as a layperson, you wonder why. Okay, just coming on to science and research, which I know is extremely important, and it's been mentioned before. You've got Dame Jenny, this building out at Harlow, I think, and some long-standing interest in doing something with it, but uncertainty about what's going to happen to it and where, in the long term, your science infrastructure, your key buildings are going to be, whether it's going to be Harlow or somewhere else. Have we got any further towards deciding that?
Mr. Brittain might want to come in, but if I start, so I think the important thing here is recognising, and I feel it a strong responsibility to ensure that the country has the right critical infrastructure for the Health Protection Agency to work appropriately. It is part of the national security system as well as the sort of health service as well. As you allude, I think this goes right back to 2006, so actually 2 or 3 predecessor organisations, when it was first flagged that some of our high containment laboratories particularly, but other supporting laboratories as well, would need to be replaced. That is now quite a critical decision in time frame because it takes a long time to build these highly specialised units, but actually equally to commission them into service. They have to be, for obvious reasons, tested really hard. So there was a plan which was had been agreed in the time of Public Health England for a science hub to be built at Harlow, and that's the infrastructure you're referring to. There was a review of the build, as you would expect, of the case when the Health Security Agency came into being. Immediately we had time after the pandemic, that was back in 2022, and obviously the costs, for a number of different reasons, which I'm happy to go into, but even quite simple things like inflationary and technical specifications have gone up considerably, and not unreasonably, I think ministers wanted to review whether that was the right location or an alternative one. The short answer to where we are at the moment is it is under very active review by ministers. I think we can be assured of a decision coming through the second part of the spending review. We have been working very closely with Cabinet Office, with Treasury, and with other parts of the science system as well, I think, to make sure that there is coherence for all of our science laboratories across the patch.
So the short answer then is this is essential that we get something in place.
Absolutely.
And it's important we get a decision quickly.
Absolutely. And I'm confident that that is clearly understood and that is being actively addressed.
Jenny, do you have an exact specification of what you want to do? And once you get the resources allocated, the money allocated, how long will it take to construct?
So that depends on what is decided. I mean, these are multi-billion decisions, which are quite rightly cross-government ministerial decisions.
Well, it's held as an asset under construction in the accounts of 297 million, so we're talking about a lot of money.
It's a technical impairment on the accounts for that year, but it would come back if Harlow is the science hub location of choice. That will come back into the accounts in due course. So that's a bit of a technical auditing process. There has been a spend of around 400 million on the Harlow site. I mean, there is a visible build there to a certain level. The science hub and the alternative option, which is a longer term programme, but eventually delivering the same type of approach, would be at Brittain. So we have a lab there already, and there are opportunities to do that. They are slightly different specifications. One, Harlow, we would go almost back into business straight away, and the Brittain one we would replace with a similar high containment laboratory, but then refresh other laboratories to support it over a longer period of time. In response to your question about are we ready, we have done exactly what NAO suggested we did, which was actually have a long discussion with the IPA team about what the right model for overseeing that was. We took on board the fact that I am not somebody who normally goes and builds large laboratories in countries, and we recognise that. Having said that, these are so specialist that they do need a lot of very close technical oversight. I personally have been out to a number of other places, so I've discussed in South Korea, for example, where they have just built a similar laboratory, what was the oversight, not just what was built, but what was the oversight of that build. And it seems that having the technical oversight is the right model. Canada also are very experienced in this, but we have put in place a new team. We have a new SRO for this. He's been working to provide ministers with updated costs over the last few weeks, and I think we are ready to go. We've got new commercial services ready to go.
There are two projects, one at Harlow and one at Brittain.
There are two options. They are slightly different. They're slightly apples and pears. But if you go forward over 40 years, I mean, this is their timescales are very different. The country maintains all the services that it needs in health protection terms, but the actual buildings happen at different times in different places, and our staff movements would be slightly different.
Which is the priority, Porton or Harlow?
Well, that is for ministers quite rightly to decide, because the two sites have very different options and opportunities. The Harlow site is sitting much more in the science triangle. There are opportunities there, which again we have discussed with the organisation for MHRA to be on the site as well. Equally, at Porton, we've been working with MOD, with DSTL, to see how we can work with them on a different type of campus. And they have different elements which ministers are considering.
But to be clear, it's likely to be one or the other,
yes.
Not both.
Yes.
Sorry, just
It's likely to be one or the other in terms of
Right.
new builds, not both.
Yes, absolutely.
Right. But then Dame Jenny was saying that they have slightly different functions.
The reason that this has been quite a prolonged decision-making process, I'll put it that way, is because the pros and cons of them are difficult to judge against one another, and they have different financing profiles. It's quite a technical area. I could give you an hour's worth on this one. Actually, I'm not going to, but you'll be happy to know. But just to say that there are some differences and some pros and cons to each, and because it's so finely balanced, this is why it's been quite a difficult decision to take. But the sums involved are large, which is this is not a decision you can take without thought.
So I think we'll leave it there, given that it is so technical. We may want to come back to that, and we may ask you questions, but that's really helpful for now. Anna Dixon.
Yes, and conscious of time, I'll try and keep the questions short and encourage you to be short in your replies. So just want to come on to a couple of issues in the accounts about unapproved payments. So I think this has been a historical issue of ineligible medical practitioners receiving payments, and just really what progress, Julian, Kelly, please, have you made on recovering this 2.3 million?
So on the specific of the past, there are 14 GPs. There are 5 from whom we've fully recovered. Admittedly, they're the smaller cases. It's about £100,000. There are 5 which are in progress. That is worth just over £1 million. That is in progress. There are 4 cases where we won't be able to recover the funding. That is worth about £1 million, because either we are past the statute of limitations, 6 years point, or the historic teams failed in the process to follow the determination which led to the person being suspended. So we have lost the right to recover the funding. I will say we have changed the arrangements. We've put in place a single national team, and since we did that, we haven't had any more cases, although that is still subject to audit by our external auditors.
It was error rather than fraud.
Yes.
Okay, and you're confident that hopefully the new process will work.
Yeah.
So another aspect of people and money is special severance payments. Again, protocol is that these should all get Treasury approval. It seems again that NHS providers, they've made some 51 special severance payments, totaling a cost in this year of 23-24 that we're looking at of over some £900,000, 5 not approved. Can you just again update us on progress, both with addressing these approvals and indeed making sure it doesn't happen again?
I mean, we continue to work. I mean, so every case which is not properly approved is wrong. We continue to work with providers and indeed ICBs across the country to remind them of their duties. We do regular training sessions. We have spoken to the individual organisations. I mean, in one case, I actually think the decision that was made was a better value for money decision than if they'd just done almost a normal severance payment, but they did not seek the right approval for it. So, it is just reminding people exactly what the process is. I cannot promise that across an organisation this big we will not continue to find examples, in the future where people fail to follow some bit of process, but we're working absolutely to kind of avoid as far as it's possible to do. And clearly with the discussion we just had earlier about some of the changes that are going to go on, we are going to be reinforcing this message.
So what's the total amount that there's been spent across the NHS on severance payments in general, not just special?
I must admit, it will be here in the accounts. I do not, I mean, you could probably refer me to the page, but I actually don't have that number at my fingertips.
Okay.
I think it's table 38, page 189. This gives you some...
I'm just wanting to get a sense of whether, you know, over time the use of this is going up or going down. Obviously, you know, there can be reason for that. But I also want to come to another related point. So, chair of a local trust, and I realise you wouldn't wish to comment at all on an individual case, but it was removed after raising some serious safety concerns, and he is currently going through an employment tribunal, which is why I would not be drawing attention to the specific case. But I would like to just really ask, you know, how much the NHS is spending on legal costs to defend itself in such claims. Again...
my apologies, I'm trying to find the table, and because of the way it's printed out, I mean, we can confirm the precise number outside of here. I mean,
it looks as though from
individual organisations or boards are clearly responsible for their own governance. We remind them constantly of their responsibilities and duties. Where we discover that something has been done that is untoward, we sometimes do get involved as appropriate, and will take, if it really comes to it, the right regulatory action, or indeed to carry out the kind of right investigation to make sure what has been done has been properly understood. But I can confirm outside of here the precise numbers.
Yes, and I think there isn't currently available a publicly available breakdown of the legal costs as they relate to exit packages, employment tribunals, or such things. And I think it would be useful for this committee if you could follow up, just to provide us with that based on the sort of consolidated NHS provider accounts, so that we can track. Because obviously, you know, in terms of whether this is really a good use of public funds to be pursuing individuals and these the level of those legal expenses, it would be keen to see that, please.
I think if you look at tables 38C and 38D on page 191 of the accounts, it looks to me as though in the latest year, the 31st of March 24, it involved 4,402 people at a cost of 118 million.
Okay.
Yeah. What I think Anna Dixon's question is sort of getting around, particularly the first part of the question, is if we know from this morning's announcement there are going to be very large numbers of redundancies and severance payments and so on, is there going to have to be a new mechanism for approving this? You can't have every single one of these people approved by the Treasury. How is that going to work?
So, I mean, on this is yet to be decided, but in the past when we have run similar schemes, there's been an overarching business case for the overall numbers and cost and time of the people that we are looking to leave the organisation, and the Treasurer has approved that sort of envelope, and then processes have been set up inside the DHSC and NHSE to manage that and ensure appropriate governance is in place to make sure sort of the individual cases are managed on an appropriate basis. So
and a fair basis.
And a fair basis, yeah.
Yes.
So I imagine that will happen again.
I think the fair basis is very important given the legal costs and not going down the route of having more employment tribunals.
Yes, exactly.
Thank you.
Carry on?
No, that was fine. I was just making that point. Thank you, Chair.
Fine. Clive.
Yeah, just following that. So the 240 in the accounts reference to 240 identified cases where retrospective approval was sought for special severance payments. That seems a lot. What happens if approvals turn down retrospectively?
I mean, the technical accounting thing that happens is the external auditors make a judgment as to whether it is material by value or nature, and if they judge it is, then that would lead to potentially a qualification on the accounts. In the particular instance of NHS England, I can't speak for the broader position. The judgment this year is it isn't material by value or nature. It's not revealing a systemic failure of control, even if there are, issues that do need to be addressed organisation by organisation.
Are there any consequences for those who approve these payments if they're actually acting outside their remit?
I mean, it's a judgment about how proportionate, the response is in each individual case. I.e., we have had issues where they're like a systemic failure of control, and then we have taken regulatory action in some instances. For example, if I have an HR director, they have given approval before they have sought, the right authorizations, but depending on the sort of sum involved and what's happened, we'll talk to the organisation, we'll make sure people are spoken to, but it's just working out what is the proportionate response.
Has any action actually been taken against anyone for any of these payments that were given without proper approval?
As I said, we have followed them up in the way that I have just said, and in most cases the proportionate action would be to remind folk actually the authorisations they do need to get.
Someone might think that constant reminder and reminding isn't really working if they keep occurring.
Well, in an organisation the size of the NHS, I will just say we will find, it's why I can't promise to you that you won't have them again, because in an organisation the size of the NHS, we could easily find, I will just use the example of an HR director who's come in new and has done something without actually properly having understood all the authorisations that are needed. As I said, we just make sure proportionate action is taken.
Right, okay.
Thank you, Clive, very much. Anna Dixon, please.
Okay, we're on clinical negligence.
Well, I was thinking you were going to ask on inflected blood.
Yes, I am. Yep. Thank you, Chair. Obviously, we had the final report, the infected blood inquiry, in May of last year. And as part of that, the new Infected Blood Compensation Authority has been set up in the meantime, I understand that DHSC is remaining responsible for making some of the interim payments to infected people and their families. Obviously, the Chancellor committed the 11.8 billion of funding needed for the compensation scheme in the autumn budget. So how are you ensuring that with this transition to the new Infected Blood Compensation Authority that all those entitled are receiving payments due in a timely way?
So I'll answer that one.
Yes,
look, obviously, given the sensitive nature of this issue, we want to make sure the transition goes absolutely seamlessly. So what we're doing, we're supporting the Infected Blood Compensation Authority to set up and establish its operational functions and learn from the NHS BSA, which has been running the support scheme since 2017. So there's a lot of interaction between the two organisations. We've provided the relevant information for the Compensation Authority to process compensation claims, and we've digitised about 7,000 records and transferred those to IBCA to enable them to process things quickly. We're also supporting them to get information and be in contact with the relevant organisations and obtain the necessary information, for example, NHSE and GP records and things like that. And as part of that, we are agreeing appropriate transfer dates. So we won't transfer until we know the Compensation Authority is in a up and running effectively to be able to transfer. So we're in constant support on that to enable a smooth transition. And actually, it's already started. So the Compensation Authority has made about 11 offers worth 13 million. So the transition is starting, and we are looking to a date of around March 26 for that full transition to be put in place. But we will continue offering support to make sure it goes well.
Sorry, what was the date for?
Around March 26, I think, is the latest.
26.
Yes.
And in terms of the accountable officer, to make sure there's real clarity on who is accountable for.
I would need to check, but I believe that will be the same time.
Okay, so in the meantime, it would be sitting with you, Sir Chris, until such date. Okay, thank you. Unless colleagues have any supplementaries on that, I would like to move on to clinical negligence.
Could I be troublesome and just come in here? It troubled me, Andy Brittain, that when we were preparing for this, all those who are registered with the IBSS Infected Blood Support Scheme before the 1st of April 2025 will continue to receive support payments for life. Is it, and I can understand the reason for putting a cut-off on it, you don't want future people coming in, but is there a chance that anybody who is affected by this before that date will not have registered and then will not be eligible for the payments? And if that's the case, what publicity are you making to make sure that everybody who is eligible does register?
I absolutely understand the point. I'm afraid I don't have the answer to that at my fingertips today,
Could
so
you
we'll
write
follow up
to
on
us?
it. Yes, of course.
It would be
Yes.
very helpful.
But there is some transitional arrangement, just to be clear.
Yeah, but I mean, this is potentially, really important stuff.
We will do.
Thank you. Thank you, Anna.
Well, thank you, Chair. It's very important that all those who were victims of this scandal do have their right to compensation. So thank you for that. Yes, moving on to clinical negligence. So looking in the accounts, we see very large numbers in terms of the liabilities and costs relating to risks to do with clinical negligence. So the provisions here were 58.2 billion as at the 31st of March 2024. We have previously requested and had correspondence wanting data that enables us to track trends in clinical negligence claims over time. In particular, it came up in our hearing on the whole of government accounts that the discounting tends to distort and make it much more difficult to understand whether these liabilities are actually going up or down. And so I would like specifically to ask whether you could update us on whether claims, excluding discounted rates, are actually going up or down.
Look, I mean, I can answer that. I mean, obviously the causes of this are complex. And they include higher payments and legal costs. I mean, the number of claims has gone up, but mainly that is because of new schemes being added, such as the clinical negligence scheme for GPs. If you sort of strip that out, the number of cases is pretty static. The number of claims is pretty static once that's been stripped out. As I said, the value of those trending over time is tending to increase though, because the number of the cases themselves are becoming more complex, and therefore the payments are becoming higher. So that's the trend.
So behind this, monetary figure obviously lies tragic incidents of patient harm. And, obviously we would like to see the NHS really recognising that it should be doing no harm. And so I would be grateful if you could say a little bit more than is in some of the performance reports here about what are you actually doing to reduce patient harm and advance patient safety, and will this remain a priority in the 10-year plan? So Chris, perhaps.
Yeah, so I mean, firstly, I think all of us would fully agree with that. I mean, the ideal number would be 0 in terms of cases of negligence, because as you say, each of these cases it has a tragedy behind them. A patient, either themselves or their parents have made the claim on their behalf. In the cases of the maternity cases, there is a lot of work being done to try and improve that the whole time. I mean, the chance of getting to 0 are actually low, but improving we absolutely can and should do. I think it's important to differentiate between the things which are the large numbers in terms of numbers of people affected and the large numbers in terms of amount of compensation to the individuals, but also therefore cost to the public purse. A very high proportion, I'll take the second first, because this being the Public Accounts Committee, over half of the costs actually come from maternity cases, and relatively small numbers of them, because the cases per case are exceptionally high. Now, I think there is an interesting and important question of policy as to have we got this right in the way this is done, and particularly noting you could have a child who had the same injury due to no negligence, just due to natural accident of birth processes. Birth is a dangerous process, who would get nothing because there's no negligence, but they have the same disability for life. And I think that's one question. I think a second question, which is I personally as a non-lawyer think is worth considering, is
is the proportion of the funds that you've talked about going to legal fees actually appropriate? 19% go to the lawyers who are bringing the cases. Those are very large sums of public money, and I think that's something which should be looked at extremely carefully. And of course, there's some costs are for defence as well. But your fundamental point, which is actually the key to this, should be principally to make sure we get safety as close to perfect as you can. Accepting absolute perfection is a very seldom possible in a complex system of biology like medicine. And I think we would all recognise that maternity, in addition to being expensive medically legally, is also an area where we should be improving in terms of quality in many parts of the country, not all. And that's not to undermine the outstanding work that done by midwives, obstetricians and teams around them to support mothers. But there are very unwarranted variations in maternity and neonatal outcomes by geography, by ethnicity, by age, by a variety of other things, which, irrespective in the sense of the monetary value, absolutely need to be dealt with. And I think you can say the same in many other areas of practice. But so I think your underlying thing completely, in a sense, I agree with, but I do think there are these other issues that we need to bear in mind, both, and I know that the National Audit Office is intending to do a review of this. I think that will be a good opportunity for us to look at this actually in the round. Early in a government is when they're have the time and opportunity, I think, to either decide to take a serious look at this or not. It's a complex area with quite a lot of interlocking elements.
And sorry, apologies, Chair, I should have put as a declaration of interest that I am an officer of the all-party parliamentary group on patient safety for this part of the discussion. And certainly I was going to draw attention particularly to maternity outcomes, whereas as you say, Sir Chris, while they might not be the largest number, they do account for the largest cost. In my previous life, I did a report back at the King's Fund in 2008 called Safer Births, with many recommendations, and there have been numerous reports since. And yet it does appear that we really are still not delivering the outcomes in terms of safe births for the majority of women, and certainly some of those inequalities by race and other factors that you describe are really still a scandal. I read in the report on page 28 numerous delivery plans, oversight groups, action forums, independent working groups. It seems a lot of activity with very little result. So, I mean, what would your sense be about how do we get a grip on this and do better?
Well, I mean, I think that I would be very cautious about saying that activity has no impact. I mean, I think that a lot of concentration has gone on safety, and thanks to many campaigners, yourself included. Actually, my predecessor, but one, Sir Liam Donaldson, did a lot on this, and Jeremy Hunt, when he was the Secretary of State for Health, put a lot of emphasis on patient safety, for example, as all ministers have since. The fundamentals, though, are really about two things. Increasing the probability that a mother gets too close to labour and goes into labour in very good health, and that's a prevention and a primary care as well as a secondary care thing. If you don't go into labour in good health, clearly there is a much greater risk. And then improving the pre-immediate birth and post-birth outcomes, because some of the outcomes are poor from neonatal, so it can happen actually after the baby is born due to sepsis or a variety of other issues. Each one of these components, I think, needs looking at quite systematically. I've also, for a while, and this is not a clinical negligence point, this is a general point, been worried that the join-up between obstetrics in my profession and neonatal paediatrics is not as good as it should be, and that there's actually a potential gap between those two into which the most critical and most dangerous day of anyone's life, which is the day you're born, sits. And so I think there is a lot of things we can do which are on the clinical side with midwives, with obstetricians, with neonatologists, but also with the preventative services. I should say there are two other things which are probably just worth bearing in mind. They are both good things, but they have a risk. The first is mothers on average are older, and that does have higher risks than it historically would have done. And fortunately, many mothers who previously either would not have survived to the point of having a child or alternatively would have been very, very strongly advised not to. Modern medicine allows that to happen, but these are high-risk pregnancies. So there are material changes that have happened over time, which are actually a sign of good things rather than bad things. Nevertheless, there are clearly things that can improve, and each of these cases has been proved in a court to be actual negligence. So you can't argue that there has something has gone wrong in these cases because it's been examined in front of a judge very carefully.
And I would also just concur with your point about the lawyers, and certainly would hope that NHS resolution would look more closely at how it could reduce the sort of legal component and indeed consider no-fault compensation. Is that something that's on the agenda for NHS resolution?
Well, I think there are two bits to that. The second bit, no-fault compensation, that is a huge change that I absolutely would require a minister to consider it, and there are big pros and cons, and there are systems around the world that have done that, but in general they've tended to be more expensive overall, whilst arguably making less of a differentiation between those who have the same injury by accident and by negligence, but with the same outcome. So that's a very big, in a sense, my view is that is a political choice. The question about how many people does the NHS, in a sense, fight the case in court, a very small proportion, less than 1%, I think, from memory, of the cases actually get to trial. So those costs are not there, but there is a hazard to that, because there is also an issue of public funds. This money is not coming out of nowhere. It's coming out of other health services that would otherwise be used for other things. And so if no case is fought, when actually the views of the clinicians are, no, this was not negligence, this was genuinely a terrible thing that's happened, but not due to negligence, it is just a terrible thing that's happened. That happens a lot in medicine. People do die and have injuries in medicine with perfect treatment, not as a cause and effect, but because it is a hazardous area. You have to get that balance right, and I think I wouldn't certainly want to push them to go even further to never ever take case to trial. At the moment the numbers are in fact very small.
Okay, thank you very much, Sir Chris. I could go on, I'd love to discuss patient safety all day, but I
one
couldn't see to others.
use, Chris, and we're getting a huge benefit of you being here with your knowledge. If you look at the table on page 309, I don't necessarily suggest you go there, but taking constant discount using the same rate of interest, it looks as though the provision in April 23 was 69.3 billion, and it had gone up to 72.7 billion by 24. Is it because of the answer that you gave, these systems are getting ever more complex, and therefore it's likely that these sums are going to go on increasing, or are there things you can do with training and one thing and another to start to limit this huge figure? I mean, 72 billion spent on clinical negligence is, as you say, money that could be spent elsewhere.
So, I mean, on the technical question you asked, I tried and failed to work this out on the discount rate, which changed. I'm very
on a constant basis.
No, I know, but what I'm just saying is there are a variety of ways in which you can calculate it, and I decided I would wait for the NAO to do what they do brilliantly and bring clarity to this, because accountancy is not my principal skill. But your bigger point was absolutely right. I mean, you would expect the number of complex cases probably to drift up because of the increasing complexity of medicine and the fact that people who have complex needs are actually surviving longer, which is a very good thing, but they are also ones in which medical accidents are more likely to happen. But that's not a very large effect in my view. You're obviously going to get some increase because of an increase in the size of the population. That's a straight demographic one, and ageing has an impact as well. Again, that's a more complex one, but it definitely does have an effect. However, there also has been more cost per case, all other things being equal, over quite a long period of time, and I think that is not fully explained. And my own view is the basis on which costs for individual cases are calculated, which includes in many cases assuming that people will get all of their care from the private medical health care rather than the NHS, has always struck me as a surprising approach to it. And I think these are the things which maybe after the NEO report we could look into in more detail, because there are many components to it.
I gather that the NAO are going to do a piece of work on clinical negligence, so we will be coming back to this. There's no question. It is a really important subject. And in view of that,
very small supplementary,
okay,
if I may, and just to get this on the record, particularly for the data coming back, I realise there are a lot of different assumptions behind future liabilities. I'd be really keen to know whether the Cumberledge reviews first do no harm in relation to the pelvic mesh scandal, which has affected a number of my constituents, obviously mostly women, the implant scandal and some of these other scandals, whether there is estimates in for future liabilities from those scandals.
From memory, I think the answer is yes, but I'm not confident in that, and we'll need to write to you about it.
If we could have that in this follow-up note.
Yeah, we can easily. We should obviously do that as a follow-up note rather than me trying to do it from memory.
Yeah, because obviously that's quite a large scale.
Thank you very much, Anna. That's very, very helpful and Chris's answers. Clive Betts, please.
Yes, probably. We're here this morning being able to ask questions, probe into what's happening in the NHS, because we've actually got accounts that show us and gives us information. Unfortunately, I think the information is that a fifth of NHS bodies had their audits late. They simply weren't ready on time. Why is that? Is there anything we can do about it to make sure there's a significant improvement in future years? We set a deadline, which for the last couple of years has been the end of June. The number of organisations meeting that deadline has been lower than it was pre-COVID, but is improving. So last year, I think I'm right in saying it was about 83% got in their accounts at the end of June. The previous year was about 79%. So that is improving. One of the reasons is definitely the overall pressure on the local audit market. And some of the, I will say, sort of trade-offs that audit firms are making between doing the kind of local authority accounts and NHS accounts. Nonetheless, we are still anticipating year-on-year improvements. There are some issues which I think are unavoidable, where, for example, we do have some organisations who are also dependent on closing out local authority accounts where they have liabilities with respect to local authority pension schemes. So I'm expecting year-on-year improvement. This year we start closing out 24-25 with every single organisation having an auditor, which I think last year there were still a couple at this point. We were still seeking to get auditors in place. So we're in a much better position. I expect to see continual improvement. Are there any failings within the NHS bodies which are causing this, or is it all down to auditors?
No, I don't think there are any systemic problems on the NHS side. We have had one or two examples where we've actually had like a failure in a team. I hasten to add, not last year, but we'd had an example a couple of years previously where we had an organisation where we just had a failure within the organisation, and in the last couple of years we had a material problem with one audit firm who was auditing a number of the organisations, which was why they were late. That audit firm is now doing a much smaller proportion, less than a handful of providers, which is why I think we will see continual improvement. But there is not a systemic problem on the preparing side.
The other systemic problem you've mentioned are probably where you get into pension. A lot of local authorities are struggling with that as well.
Yeah,
I think
yes.
So do you look there at qualifying the accounts of those particular bodies where you've got a problem evaluation of pension liabilities?
No, that in some cases it just takes longer than we would otherwise like to close the accounts. In all instances, we have managed to close the accounts without a qualification. I think I'm absolutely right in saying that, and if I'm not, I'll confirm outside of here. So, but it does just mean in a handful of cases it takes longer. Now, we have worked really closely actually with the National Audit Office to make sure that we can still close the national accounts even if there are a few, like a handful of organisations where they have not yet closed the accounts, and we have sort of alternate assurance procedures in place.
You mentioned local authorities there, where clearly there's been a much bigger and more systemic problem with local audit. A lot of that is due down to the problems of pensions and other assets in the accounts. So have you been actually working with MHCLG in terms of them developing this backstop position and then trying to improve the whole position of local audit going forward?
We have. I mean, Andy may want to say more than me, and is probably even more closely involved than my team is involved. I mean, we have. I don't know if it's the advantage but we've been in the position where, because individual providers directly procure their own auditors, I think we've been able to be reasonably flexible. We have seen new providers come into the NHS market. We've probably been more flexible in, frankly, being able to pay more because audit fees, we've roughly doubled the fee we're paying for audit. But we are working with MHCLG and with the department and indeed with the National Audit Office to make sure that, you know, future audit arrangements are sustainable both for the NHS and local authorities.
Just to add to that, if I may, I mean, we're absolutely closely linked in with the MHCLG and their consultation that's out at the moment. I mean, the two key parts for us are the proposal to sort of incentivise more key audit partners within firms so that they can sign off more audits, and also the local audit office as well, as you said. So both of those should increase the capacity of the market as it is at the moment to process NHS audits. And it's worth saying, I mean, Mr. Kelly said the deadline at the moment is June. In order, and I suspect this is where your further questions are coming to, in order to enable a pre-summer recess laying of our accounts, we would need that to come forward to May. So we do need to the end of May. So we do need quite a significant increase in the capacity of the local audit market to process NHS audits.
And that's going to depend on the development of the local audit office, isn't it, realistically?
Yeah.
The private sector is not suddenly going to develop and expand significantly. So there is a time frame then. So when do you think that real capacity is going to be there? Have you got any objections?
The proposal is out for consultation at the moment, so I'm not sure an actual date has been put on it yet, to my knowledge. I mean,
look, I'll be straight. I don't think we will get there quickly until such time as you see the increased capacity, and I don't have a firm time frame for when that might be, because you say it links directly into what is going on with local authorities, and the local auditors are clear to us at the moment they can't go faster than in June.
And the consultation that's taking place, you're very closely connected with that, and your views and your concerns and your requirements have been taken into account.
Yes, absolutely.
Yeah. Okay. Budget.
Well, I think we may come back to this because it's a really serious matter, because it affects the whole of government accounts. And, you know, you're committing to a month earlier each year, but that takes you for another 5 years. I don't think we can wait another 5 years to get these accounts done on time. So I think we will probably want to ask some questions and come back to this. But in the interest of time, I think we need to move on. There are one or two things that I would like to cover, please. And I think probably some fairly quick questions, some fairly quick answers for you, Mr. Brittain, if I may. Really important subject of productivity. There's a sort of a fairly dense sort of table on page 126, but there's not much else. Could you let us have a fairly full note on productivity? Because productivity is, you know, at the moment, the increase in expenditure on the NHS is probably unsustainable in a longer run. So the one way we can probably start to address that is through better productivity. So can I ask you, A, to let us have a note on that, a fairly full note, but B, to pay more attention to it in future years?
Yes, of course we will. And just to reassure the committee, this is absolutely one of the top priorities for the department, looking into the 10-year plan and the spending review, because we're seized of the issue as well. So we will provide you with a full note.
Just 30 seconds.
Yeah, of course.
So as we've said before, NHS productivity is recovering. Acute sector is improving by over 2% a year as we sit here today. We are for the first time measuring productivity on the non-acute side with community, ambulance and mental health trusts, our first estimates this year, as that is improving by over 3% year on year. I mean, that's early data, and I think that is less, that is going to mature over time. We are clearly focused on how we improve next year. We've set a very challenging goal for systems, which is like, can we get closer to 4? We have benchmarked every single organisation. We've shown them where the opportunities are. We have a plan to train 20,000 clinical and operational managers in the sort of re-equipping them with some of the operational management skills and improvement skills we need. We have a plan to invest in putting senior clinical leaders into, around 40% of trusts in different intensities to focus on how can we improve flow through hospitals, how we can improve productivity of outpatients. And clearly, we've got a plan for next year to continue to maximise the benefits, not just of putting electronic patient record systems into every trust. By the way, that when you do, they're about 13% more efficient for each admitted patient, to continue to develop the NHS app, where we have already saved millions of hours of administrative time, and to roll out the federated data platform, which, for example, in the trusts in which we have put it, they are basically operating on about 119 more patients per month per trust, which actually, if you aggregate that across the country as you roll it out, is a significant gain. So really focused, concrete actions in place, recovery being shown day in, day out.
That's really helpful. Now, you may well want to come in on this next question, which I was going to ask to Mr. Brittain, but I'll ask it to you. We are in this committee very keen on technological improvement, digital and AI improvements. It was therefore surprising. The only reference I could find in the accounts was on page 337 in one small paragraph. I do think we need to pay a lot more close attention to this whole area, and that is linked to productivity. So I don't know whether you want to comment on that, either Mr. Brittain or you.
I'll go first. Absolutely, and that's another area where we'll pay more focus on in next year's accounts. I'll undertake to do that. As part of the spending review and 10-year plan, we're absolutely developing a refreshed tech plan as part of the productivity plan, which will be looking to increase and transform productivity going forwards over the 3-year spending review period, and that will include sort of the tech programs Julian has mentioned, but also seeing the extent to which we can roll out AI across the organisation as well.
Really helpful. Agency staff, you have a sort of a reference to it on page 187, table 36, costing 5.6 billion. Actually, a slight improvement, I think, on the year before. But is this still an area that you are bearing down on?
Well, certainly in the NHS, agency spend 2 years ago was £3.5 billion. We are forecasting we'll end 24-25 with agency spend of just over £2 billion. That's clearly like a really material reduction. We will continue to bear down on it. We've set a goal to reduce it by another third next year.
That's really helpful, Julian. Thank you very, very much. And the final question on my list is social care. Now, I know the government, this has got a long-term review in it, and some people in the debate on the estimates a week or so ago were saying it's going to take far too long to leave it till 2028. But I suppose a question, I've looked in the accounts, there isn't a lot, there's a little bits in the accounts. But is there anything any of you can suggest as to how we can improve the delivery for patients by a more seamless working between social care and which of course is delivered largely by local authorities. So it all comes into this whole debate we were discussing earlier of government reorganisation and so on. But is there anything in the short term that would actually help us this sort of seamless operation between the two organisations?
You go first and I'll go second.
Well, on viewed from the NHS perspective, a lot of work is already going on. We have NHS organisations, the general move has been towards having joint social care and NHS assessment teams within NHS trusts, so that you have a single process for assessing what is the care package that is needed, how should it be delivered to speed up the both the process of discharge and getting people where you really want them, which is back home. Now I think we have seen some progress on that. Length of stay is down in 24-25 by about 2%. That will be in part because of that work. We have done work over the last 18 months looking at how we can improve intermediate care, which is basically providing sort of physical rehabilitation as you're leaving hospitals, which is currently commissioned either by the NHS or by local authorities, depending on where you are in the country. So it really does matter that we work on that together. We're looking at how we roll that out next year, and we've begun some work, for example, looking at how you really deal with frail elderly people who really can be better cared for at home. And we're working with 7 places in the country to see, can we really create, I'm going to call it the best practice pathway, which is actually absolutely going to involve working between acute trusts, community services and domiciliary care providers. So that's the work that is going on to see how we can improve, continue to improve things.
That's really helpful. Thank you. Anna Dixon.
Yes, likewise, just a couple of quick supplementaries. Following on the point on social care, in the accounts on page 278, it does seem to break down, and I always get my noughts muddled up, but I think it's about 1.4 billion purchasing of social care by the NHS. The feedback from a lot of social care providers is that the NHS is a really poor commissioner, undercutting of sometimes local authority. So great what you've just said about more seamless working, but where you are purchasers of social care, can you please do a better job of it?
You're quite right.
Learn best practice in the local authority. Probably don't need to respond to that, Julian. So my other quick points are that breakdown by...
Just to come in on that.
Yeah.
I mean, discharging of hospitals, it's been sorted now, but there was such a bad problem in Gloucester Royal Hospital. The ambulance were queuing up so much, even onto the helicopter landing point, and the helicopter was in the air, having to wait for the ambulances to be cleared. I mean, this is a chaotic system. I know it's been resolved. I was going to ask a Prime Minister question on it yesterday, but there is a real problem of these discharges, and particularly places like Gloucestershire.
All of us agree on this panel.
Yeah.
So yes, in that typology of breakdown of costs, and I apologies if I've missed it, I didn't really see anything which gave a sense of how much we were spending on palliative or end-of-life care. And indeed, in the performance report, which goes into great detail on many topics with pages of information, there are but 4 lines, 2 sentences on your performance on end-of-life care. I mean, in the interest of time, I guess this is a question to say, given the importance and the costs that are spent, we know, on people in the last 6 months of their life, it seems a huge omission that nowhere in this report can we have any accountability for what is being spent on palliative and end-of-life care, nor indeed what outcomes that is delivering. I don't know if you would wish to respond to that briefly.
Yeah, you give a number.
I mean, we'll just check. Well, I don't have the number off the top of my head, but we'll definitely change that again for next year. We'll add more prominence to it.
I mean, it's a very large and multi-layered area where a lot of end-of-life care is just good care for things, and I think there are bits like sort of hospices which are very clearly just end-of-life for many people, not exclusively, but actually, we will all die and we all need end-of-life care. It's central to medicine. I think to give you a serious answer to it would take a long time, but it does actually deserve a serious answer at some point. I don't think it's one where Treasury Minute will help. We can give you the numbers, and we can do that now. But I think if you want to look at this seriously, I think it is a big and important subject.
Yeah. And on similarly, mental health. Was pleased to see on page 22 of your annual accounts that all ICBs did actually meet the mental health investment standard. I believe that there is a commitment to continue the mental health investment standard. Yes. Yeah. Could you just confirm until what date that commitment has been made?
Well, at this point, the money we have given and the planning guidance we have given is for 25-26. Clearly, what comes thereafter is the subject of the spending round and then what follows.
Yeah. So I think there is some mismatch in a way between the things that we're interested in knowing what we're spending and what you've got in the accountability report and your typology breakdown. where there are some large categories which just say clinical services or community services, and it's quite difficult from transparency point of view to understand where money is going in terms of the things that we know to be priorities for our constituents and for the
reflect
public.
that in the next set of accounts.
We'll try to do that with the caveat we want to keep it as one volume.
Oh yes, no. It's more than numbers, the typology. There's more than enough information on some subjects.
Yes.
I just don't think they truly reflect the priorities that the public and patients have. There's many things more we could discuss, but I'm sure we will have other opportunities through the public accounts to come back to them. So I'll defer to the Chair. Thank you, Chair, for indulging.
Thank you, all of you, for asking questions. So Chris, I entirely agree with you. We want to keep it to one volume. By the time I got it home last night, and by the time I brought it back this morning, my arm was well and truly aching. So I entirely endorse that. Well, we've had a really broad-ranging discussions this morning. I really do thank all our witnesses. I wish all those departing from any bits of the health service really well in their next endeavours. So Chris, thank you very much. We benefited from your expertise hugely this morning. Whether our next session will be with you or with your successor, I'm not entirely sure.
For myself, I regret to say it is with me.
No, well, your loss is our gain. So thank you all very much to our witnesses. I'm going to just do something I don't normally do, but I'm going to thank the NAO this morning. This is an enormously big subject. Very short notice, they provided a lot of information. So thank you very much to the NAO team for what you've done today. Thank our committee staff as well, and all members. Chris, yes, of course.
Chair, could I just put on record our immense gratitude from both from Andy and me to Julian Kelly and his team. Julian's done an absolutely outstanding job over a long period of time. I mean, really remarkable. And you understand that, and we understand that, but most people don't. So I would like to just put that on record as he stopped.
I'm really grateful you put that on the record. That's really helpful. So with no further ado, I'm going to close the session, but thank you all very much. All